Good afternoon, everyone, and welcome to the September 11th Board of Health meeting here at Lentz, where we have a new recording or a new system. Are we live, John? So we're live, and this recording is going to live with MNN, and we'll be able to access on YouTube, correct? Okay. Just a reminder for colleagues around the table, when you speak, you have to press your button. When you're not speaking, then turn it off by pressing that same button. So it'll take us getting used to it, but we'll figure it out. And thank you for MNN for being here today. And thank you, Matt, for helping to make all of this happen. Okay, let's go ahead and get started with the agenda. And our first agenda item is public comment. Our second agenda item, community voices. We do not have anyone who signed up for either. So we're moving to the third agenda item, which is declarations of conflicts or recusals or communiques by the board on issues that are on the agenda. Are there any declarations to be made by anyone on the board? Okay, hearing none, thank you. We will move forward with the next agenda item, which is the deliberation of August 14th, 2025 meeting minutes. They were sent ahead of time, but if you didn't have time to review, please take a moment, and when ready, I will entertain a motion. Motion made by Dr. McDonald, seconded by Quorum Powell. Okay, thank you. I just wanted to say quorum, but Quorum Powell, Ms. Quorum Powell. Is there any discussion? No discussion. All in favor of approval for the August meeting minutes? All right. Any opposed? All right. Motion carries. Thank you. And as you can tell, I'm moving quickly because we're trying to get out of here in a timely fashion today. I know individuals have appointments to get to after this meeting. Next, we have Dr. Ariola, who will lead the employee and team recognition. Dr. Ariola.
Hello, Chair Franklin and members of the board. Really gives me great pleasure to really recognize Tony. Tony, if you stand up. You know, yes. You know, what's written here, I think many of us here could have written the same thing about Tony. Always smiling, always positive attitude. The way it's written here, always rocking a smile, no matter the mess. And that's Tony that I've known for a long time, always trying to do the right things. To me, I think this is one of those employee of the month that's really, really fantastic. Thank you, Tony. We like what you do. We appreciate what you do. And I'm glad you are getting this recognition. Hey.
Thank you, Mr. Dodson. Okay.
Yes, that's it.
Great, thank you. All right, next we have a presentation, STI HIV presentation by Rachel Franklin, and then last names Reed and Foster. Ms. Franklin, so Ms. Reed and Ms. Foster, but I'll turn it over to you, Ms. Franklin.
This just turned green on itself, by itself.
That's because John is waving his magic wand in the back.
Excellent. Well, good afternoon, everyone. My name is Rachel Franklin. I am the Bureau Director for Communicable Disease and Emergency Preparedness, also known as CDEP. Really, I'm just here to introduce the presentation. I want to give all the credit to my colleagues, Kinley and Norman. This presentation is meant to highlight the challenging work being done to promote sexual health and wellness. And as part of his annual priorities, Dr. Sammy has asked communicable disease leaders to identify barriers and address them where we can. Hopefully, this presentation is the first step in bringing more people into that dialogue with some education. I always say when it comes to CDEP Bureau, no big news is good news, but I always want to point out too that no big news happening is because of very dedicated and hardworking public health investigators. So I'm going to turn it over to Kinley Reed, our public health emergency preparedness epidemiologist, and she's going to go over some data specifically for syphilis and HIV. And then Norman Foster, the STI HIV program director, will talk about the program activities, challenges they see, and hopefully some opportunities in the future. Kinley?
Good afternoon, everyone. As Rachel said, my name is Kinley. I am the FEP epidemiologist here at Metro Health Department. Normally, I focus on disease outbreaks, but today I'm helping out the Epi Division and providing you some data here with syphilis and HIV. So a couple of things to note before we get started. You can follow along within your packet. You will see all of the data. So in case I'm going a little bit too quickly and you want to know any questions or anything about that. And then secondly, you will see that the dates of the data are a couple years old. So unfortunately, right now we're having some difficulty getting data from the state. But right now there's some conversations happening at the state level, and unfortunately that's just how it is. But we'll go forward to the next slide. All right. So in terms of HIV here in Davidson County, we are seeing the majority of our cases in the central and southeast of the county, and this is also consistent with our social vulnerability populations as well. Right, and then HIV over time. So luckily overall our trend is down. However, in 2023, we can see our first increase since 2019. And then HIV by sex, so males have a higher rates of HIV, about 6 times the rate as females do here in Davidson. HIV by age group. So right now our youngest age population is really carrying the burden of HIV. So specifically in our 15 to 24 and 25 to 34 year olds, with our lower rates being among those older. And then HIV with race and ethnicity, rates among Black residents has dropped in 2021. Unfortunately, we are seeing an increase since then. And then rates among Hispanic residents are increasing, with our highest rates being seen in 2023. Linkage to care. So fortunately, we are seeing linkage to care has increased since 2017. So most new diagnoses are getting treatment within 30 days. So that is a positive. All right, so we're going to switch over to syphilis rates here in Davidson. So unlike HIV, we don't hear a whole lot about syphilis, but rates have nearly tripled since 2017. Rates among males are higher, 3 times as the female rates. But unfortunately, rates with females have also increased by 5 times since 2017. Syphilis by race and ethnicity. So we're seeing syphilis cases rising across all races, but specifically in Black and Hispanic races. And then I do want to note, so the syphilis counts by pregnant persons is not a rate. So this is obviously by case counts, and that is due to the smaller population of pregnant persons in Davidson County, and just really showing the burden of syphilis in pregnant persons. So we are seeing significant increase in syphilis counts by in pregnant persons, and this, of course, contributes back to the risk of congenital syphilis, which has a high need of resources to prevent and cure that. All right, does anyone have any questions specific for the data? I can. No.
Okay, thank you so much. And is this our data, is that comparable to national data?
It is. It's so it's
Approximately, yeah.
yes. So counterparts across the state are pretty much seeing the same thing, and then on national level, syphilis cases are pretty rampant right now.
And congenital syphilis, how many cases?
Abraham, do we know, or Norman?
For what time frame?
The same. Do you have the?
We might go back.
Was the congenital syphilis case count? It's a number.
So 26 for 2023. Right now, I don't know if we have the number. 26.
Congenital syphilis. These are all.
Yes.
These are considered cases where the baby was born, the mother did not have treatment.
Gotcha.
Yes.
Okay. So these are all congenital syphilis.
Yes.
Ooh.
I know.
All right. Any other questions for me? Okay. I'll turn it over to Norman then. Thank you.
Thank you.
Good afternoon, everyone. My name is Norman Foster, the STD HIV Program Director. So this is the why behind the information you just saw. We have our disease intervention specialists, which are primarily tasked with investigation of STIs. So we're essential in stopping the spread of communicable disease. We provide confidential, non-judgmental support to those at risk, and we serve as the link between the community and the health department, often serving marginalized populations. So here's the case investigation process. All abnormal syphilis labs received in Davidson County are entered into our database. Every one of those labs have to be investigated by our disease intervention specialist. It goes first to our surveillance team. Every year we see approximately 15 to 20,000 laboratory reports coming into our program per year. They are all investigated by our surveillance team. If those individuals need further public health intervention, it is sent to our field services team. Our field services team is responsible for going out and locating and referring those individuals into our facility or back to the facility where they were previously examined for further examination and/or treatment. If they come into our clinic, our field services team also does case management. That case management includes infection education. This is where we tell them what infection they have, what infection they don't have, how it's acquired, how it is not acquired. And then we talk about prevention strategies, where we talk with our clients and we allow them to drive the process of what they think they can do to reduce the likelihood that they will become reinfected. And then we do partner elicitation. And this is where when a person has an STI, what we know is that there are at least 3 people involved. Person in front of us, the person that they received it from, and the person that person received it from. And so our disease intervention specialists, they receive special training and education on how to elicit that information. So some of our common barriers. Some of our clients, they have limited access to transportation to make it to their appointments, especially since COVID. There's a mistrust of the public health institutions. There's stigma associated with STI and HIV. Inconsistent communication, where it's hard for us to reach our clients by phone, and then housing. Most of them, sometimes they're unhoused, and we're still tasked with trying to locate these individuals. There's their reluctance or refusal to participate in the interviewing process. And then there's the fear of judgment that we're going to disclose their information, except all of their information is strictly confidential and is only presented to those who have a right to know. Here's our staffing constraints. The high volume of reports, field work demands time-intensive outreach and follow-up. And just a quick example, we may have an address, but that person doesn't live at that address. That's where the mom lives. So if we find out where the mom lives, we talk to the mom and try to find out, well, where do they actually live? Once we go to that address, they may tell us, well, he hangs out in a certain park. Then they have to go to that certain park and try to find him there. There's a lot of work involved in trying to locate and refer those individuals in. Then there's staff burnout, because you can imagine that work is kind of taxing, because each one of our investigators may carry anywhere from 15 to 30 people they're seeing at one time. The complex social and structural factors. So there's unhoused individuals, there's individuals with substance misuse disorder, or individuals that are incarcerated. There are hookup apps where clients engage in anonymous sex. And it's not the anonymous sex that we normally think of when we think of anonymous sex. They have hookup apps now where they could hook up with a person and tell them, meet me at my house. They give them the address. Person shows up at their address. They've already prearranged what type of sex they're going to have. The person walks in the home, it's unlocked, they have sex, they leave, there's no compensation had during that time. So this all complicates our ability to locate and refer these individuals in. Next slide. But here's our opportunities. To strengthen our provider partnerships. We go out with our surveillance team and engage our providers and try to help them expand screening for early detection and treatment. One of the opportunities that was just enacted is that for women that are pregnant to address congenital syphilis, normally they're just screened at their first exam. Now there's a requirement that they are screened 28 to 32 weeks of gestation. So that was something that was brought on by the field team, letting them know, we see people in the beginning, they do not have syphilis, they show up at the time where they're giving birth and they have syphilis. So this has helped because we have identified individuals through that process already. We're going to have a dedicated congenital syphilis specialist, a person whose main responsibility is to work with individuals that are pregnant and then work with women of childbearing age. Then we have our enhanced client access. We want to be able to provide support, and this is something that we're thinking about will really help what we're doing, van services and field services, where we can even have our nursing staff be able to go out and not only provide treatment, but maybe provide a screening in the field. This will help, especially with unhoused individuals, because sometimes we find individuals, but we only find them for that day. And then we try to find them again, and we cannot locate them. And I think it would help if we find them at that point and treat right when we find them. And then we want to explore expedited partner therapy in the field using doxycycline, the 14 to 28 days, something similar to DoxyPep. And for those of you that don't know what DoxyPep is, it is a process where they're providing post-exposure prophylaxis to individuals that come in contact with the bacterial STIs, and it has been proven effective against the person later developing a sexually transmitted infection. So our staffing concerns and opportunity. A lot of things that we have done here, we provide ongoing opportunities to keep staff engaged. We've recently had some training off-site for a week, really provided by the Tennessee Department of Health, which was driven by the staff letting them know that they wanted some additional training. The recognition and celebration, we acknowledge staff who really are successful with difficult cases, who go far above and beyond what is ordinarily required. We had one individual who they went out to find a young lady who went to her provider. So our employee went out to the provider and sat with them. The individual got up and said, oh, I want to go and smoke a cigarette or something outside of the clinic. And she noticed if this client left the building, she's never coming back. So she worked with the staff to get the staff to come out, put her in a room, examine her, and get her treated. And she delivered her baby without syphilis. And then the shared decision-making. Often one of the things that we do now is it's not just a top-down approach, that when our leadership teams have an idea, we present that idea to our staff and we say, what do you think about this? Will this work? And is this something you can get behind to get better staff buy-in? And that's really helped. We have regular debriefings where we meet once a week and we talk about cases where there's no right, no wrong answer. And it's a safe space for us to talk about what's going on, what challenges that they're having. And then we share the program outcomes with our staff so that they all take ownership of the work that we're doing. Questions?
We were told to go fast.
So, and thank you, and it was still very comprehensive, and I appreciate that handout as well. For the staff, you say that there's a large caseload for each team member. How many individuals do you have right now, and how many individuals, additional individuals, are needed in order to comfortably address the caseloads? I'm just curious.
So right now, on our surveillance staff, we have 5 individuals and a lead. For our field staff, if we're fully staffed, there's 6 individuals and a lead there as well. And I'm thinking to really fully be able to engage the public the way we need, probably 10 DIS on the field side and maybe 6 to 7 on the surveillance end.
Total?
Total.
Okay.
For each one. Maybe also because we have so many labs coming in, we have 2 individuals that put that stuff into our system, because each lab, we get them electronically. But once they come in electronically, they have to be added to our database management system.
That can be added manually?
Yes, because each case that comes in that has to be added, we don't know if we have to add a, if we have to add in, and I'm sorry, your question was made, no, it comes in electronically. But there are some that come in through a fax, and then the provider will give us a call. Those will have to be added manually. And I don't know exactly what that number is, but most of them are added through they come through our fax, they're added in the system. However, each one in that system has to be managed to see if we have to create an investigation to determine whether or not that's something that requires public health intervention.
And I should add that we did get some budget improvements for these programs this year from the mayor's budget. And also add that a few years ago, because of resource limitations, some of the other STIs that they could monitor, like gonorrhea, that's not necessarily priorities right now. So definitely additional local resources are very helpful with this program. But we'll be putting those together as part of our budget improvement process.
Just to kind of get the full context, what is the theoretical ideal caseload, like the maximum caseload, where it's 15 to 20 now? What would that ideal number look like?
I think ordinarily the 15 to 20, maybe even 30 would be fine. But we have times where a person is carrying 60 and 70. And their caseload includes their case management and also their field records. Case management are individuals that I've interviewed that have given me clients that I need to go out and locate and bring in. And then their field work is where they're just assigned someone that comes in. They have a positive test and they need public health intervention. Yes, I'm sorry.
Will you tell us what you would need for the department to feel good and be able to do, like, have the caseworkers go and provide a therapy directly? Because are you doing that now, or?
We are not doing that now because we were able to do that with expedited partner therapy with chlamydia. The state will allow our team to go out and provide that information through protocol. But I'm not really sure what all would be needed. There may be some legislative things that would have to happen in order for us to be able to go out and, let's say, provide doxycycline for treatment of syphilis in the field.
I would like us to think about, if it's possible, I don't know what that looks like, but just seems like that might cut some of the barriers. If you've got a caseworker that found the person, if we could go ahead and treat them, that would be great, yeah. The mobile clinic, maybe.
Any additional questions? Go ahead, Ms. Whitehead.
I am curious why, do we know why the huge increase nationally. You said it's happening here and it's happening everywhere else. Do we know why? And this is just since 2019? Did I get that?
Yeah,
2017?
There have been all sorts of theories abound with staffing, the shortage of staffing, the funding of certain programs and things of that sort. And then the reluctance of individuals to participate with the health department and to let us know what's going on. Those things have changed over the years. And where the health department may not be looked at this point as the experts. Before we were the expert, people would call us all the time and ask us questions. And it's not definitive because I don't know if that's been studied yet, but I do know some of those things anecdotally happen just through the process that our employees go through now.
And Ms. Whitehead, I'll add one thing. Anecdotally, I've heard history maybe 20 years ago, there was what was it, Dr. Sammy, STI 2.0 or something. Whenever there's a lot of attention given to it and resources, it'll go down. And then it gets off of the radar, the resources may get diverted somewhere else, and then it starts to increase again. And I think one theory is that we've taken our foot off the pedal, and here we are.
Just a quick question on data sharing with the state. I know this has been an ongoing process for years. And are there, what's the status of that? I mean, I know you're 20, and I should have asked this when you were up earlier, but I know you have 2023 data. The state has August of 25 up on its dashboard. So is there anything we can do to assist with that?
2023 is not strange. So if you go to CDC, they're giving us 2023 data. So if you nationally, the data that they have is 2023. But locally, what we're trying to do with the state is to try to find a way in which we can get more up-to-date data. It will always be a year or two behind. I think Kinley Reed, we've assigned another EP to support CDEP. They are right now going through training with the state so they can be able to access data directly from the data system.
Okay,
so we hope
so you'll have access to provisional data.
Provisional data. It takes time for cases to be investigated and to be completed, and so we want to respect that process too.
Yeah. Thank you.
So I was speaking with Julie Schaffner at the state actually this past week. So there is a meeting at the end of this month with CDEP and their legal team over at state to discuss what the issue is with Metro specifically not being able to get their own data back. And so they are hoping to have some kind of resolution, hopefully by the end of this year, to see what kind of loopholes we can maneuver through so that metros are able to get their data a little bit easier.
All right. Is it Dr. Foster? No, Mr. Foster? Okay. Mr. Foster, Ms. Reed, or Dr. Reed? Okay. And Ms. Franklin, thank you very much for the presentation today. If we have additional questions, would you mind if we followed up with you all? Okay. All right. Thank you. All right, next, Dr. Ariola has the state of public health. Dr. Ariola, you have the floor.
Yes, and I sent the performance tracking update to you, and also you have copies. I think the big thing, without having to read through everything, is vaccine is what's dominating the national news. And I think there's also an article today in the Tennessean where I spoke to them also, and I was quoted in that article as people like Dr. Hildreth. And around COVID vaccines, you would note that the 2024-2025 vaccines were deauthorized on August 28th, and new ones, 2025-2026, authorized, but we're still waiting for ordering information and the protocols. the Pfizer vaccine for the 6 months to 2 years old. That was the EUA was withdrawn, but Moderna does have vaccine that covers from 6 months to 64 years old. And there are some states that are obviously trying to find ways to ensure that everyone has access to the vaccines. About 6 states, I think today New Jersey just joined them, where they are providing standing authorization, so pharmacists can continue to give the vaccines, but those are mostly blue states. I don't expect that to be here in Nashville. So what we are going to continue to do is to encourage our staff to, our residents to work with their physicians and pediatricians to have access to that. I do have feedback from a few people that took their children for vaccination this week to one of the pharmacies. They were able to get vaccine. They weren't asked to submit any evidence. So that's we are obviously still concerned whether carriers will continue to ensure that. I had a colleague in Kansas who is 65 plus, and she did say Medicare did not cover that, but she had another insurance that did. But if she did not have insurance, it would have cost $221. So we're concerned about those obstacles, still kind of reading the landscape and watching how things are. Thus far, we don't have internally vaccines yet, unless something has changed. It's not yet, okay. But we are waiting for word from the state so we can order a batch. But it is available in the county, as I've seen. People are getting their vaccines. I'm hoping it's not the authorized one, but so it's just ensuring that people get vaccines. And of course, Florida being the first state that removed vaccine mandates, concerning because we don't know what the impacts will be when kids come to school without the necessary vaccine. So.
Would it be possible to consider some type of messaging campaign about where people can go if they're interested in getting a vaccine? I don't know what that looks like. I don't know the details, but could you just maybe examine the feasibility of some type of campaign? I know usually if we give them out, you say come to the department, right? But if just in general, just good public health messaging, this is where you should look for vaccines.
Absolutely. As soon as we have enough information to provide directives to our residents, we'll do that, yes. Okay. Yeah.
All right. Is that it, Dr. Ariola? Yeah. Okay. All right. Thank you. All right. Mr. John Finke, number 8, deliberation of proposed regulation number 13, which is Part 70 Operating Permit Program. You have
Good
the
afternoon.
floor. Good afternoon.
Chair Franklin, members of the board. My name is John Finke. I'm the director of the Environmental Health Bureau. I stood up here in July and requested that you set a public hearing so that we could change our air pollution regulations to meet some federal mandates. We did have that public hearing on August 26th. Nobody participated. We did not receive any written comments throughout the 30 plus days that the public hearing was open. So normally at this point, I would request that you approve the regulation that we proposed to you. However, last Friday, after the agenda went out, the courts rescinded the revision. This is very new to us. We haven't heard from EPA yet. So at this time, and I believe Mr. Smith is in agreement, I'm requesting that you defer this matter for 1 month, give us time to see if it's appealed or turned over by a higher court. If it is, we'll bring it right back to you next month. If it's not, we can let you know through the director's update or something that this may be dead and gone. So.
Okay. We don't have to vote on the deferment, correct?
Well,
we do. Okay. All right. All right. I will. Is there a motion on the floor?
I make a motion to defer, just as Mr. Finke said.
Okay. Defer for 1 month?
Yes.
All right. Motion made by Dr. Ziegler.
Second.
Seconded by Dr. Griffith. Any discussion?
Can you just tell us in one sentence, like, what, I can't remember what the issue was.
It was called the affirmative defense provisions. The way the law sits now, if a company has an emergency at their facility, then they're absolved of all other sins that take place during that time. This was taking that away because you could have an emergency, you could have a fire at one end of the plant. That's no reason that a certain control device has to be turned off at another end of the plant. So they were trying to fix that, and now it's being reverted back.
Any other questions or comments? All right. All in favor of deferring for 1 month? Any opposed? None opposed? Motion carries. Thank you, Mr. Finke. All right. Next, we have Mr. Jim Diamond, deliberation of grant applications.
Good afternoon, Chair Franklin, members of the board. We do have one application for your review. It is the latest iteration of the Public Health Infrastructure Workforce and Development or Data Systems Foundational Application for $481,943. That will be for the time period beginning December 1st.
I'll entertain a motion when ready. Oh, yes.
Correct. This was the one that was on the agenda last month and taken off due to legal's recommendation. But
Wait, okay, so the motion needs to reflect, whoever makes the motion needs to reflect that we're doing what?
That you're ratifying the previous submission of the application. And I'm sorry, I don't recall the date by which it was submitted to you.
it was submitted right after the last board meeting. Nick, do you remember that? August 25th it was submitted.
So I would recommend you go ahead and ratify that action as well as the application itself.
All right, so is there a motion on the floor to ratify the August 25th submission of the application entitled Strengthening U.S. Public Health Infrastructure, Workforce, and Data Systems? Foundation application.
I can move to approve the application and ratify the submission of the FIG workforce development.
Very good. Thank you. Motion made by Dr. Griffin, seconded by Dr. McDonald. Discussion.
Yeah, can you tell us what went on after we left, or how you were able to submit it?
Sure. Legal, prior, at the date of the last board meeting, legal said that they wanted to evaluate all of the language within the grant because of obviously the changing landscape. And prior to the deadline, the August 25th deadline, Metro Legal did give us the go-ahead to submit based upon the language that was included, that there was nothing that could or would cause harm to Metro in the application. So it was allowed to go through with the understanding that we would present it to the board at the September meeting.
Thank you. All right, if there's no additional discussion, we're ready for the vote. All in favor of approving and ratifying? All right, none opposed. Motion carries. Thank you, Mr. Diamond. And now we are on to grants and contracts.
Sure. Chair Franklin, members of the board, there are 6 grants and contracts up for your review. Item number 1 is an amendment to the Nashville Strong Babies grant. This is the second amendment, which provides the remaining funding for the grant year, which we are thrilled with. That totals $312,324 for a new total of $1.1 million. Item number 2 is a direct appropriation grant from the state for the HIV surveillance and prevention, $696,500. Item number 3 is an amendment to our WIC, our Women, Infant, and Children grant. It reflects a decrease in funding of $75,748. Item number 4 is a grant from the Friends of MAC, split between the Emergency Medical Fund, the Safety Net Fund, the Foster Program, the Microchip, and the Rabies Program, totaling $20,428. Item number 5 is an agreement with the Cosecha Community Development Group for our community garden that's located at the Woodbine Clinic. There's no funding involved in that. It's just an agreement between Metro and the organization. And item number 6 is a grant to the Music City Prep Clinic for $19,200.
Thank you. Is there a motion on the floor? Motion made by Ms. Whitehead,
Second.
seconded by Dr. Ziegler. Discussion. Yes.
Can you talk us through the WIC reduction?
I can talk through some of it. We haven't gotten concrete information from the state on that. The letter was very brief, and then it said that WIC funding is dependent upon congressional action as well as caseloads. There was no congressional action on any WIC funds, and our caseloads have increased. I spoke with Ms. Lauren Cromer, who's the director of our WIC program, and she is of the idea that with 75% of all the WIC funding goes toward the purchase of foods, and we don't directly participate in that, but it's all one big funding pot. With the rapid increase in food prices, they're probably directing more of the WIC funding toward that. Plus, there are also increasing WIC cases all over the state, so there may be some further division of the funds to other areas that are, did not have their caseloads previously that they do now. So we are still working to get some more information from the state about the kind of the formula and how this number was, found. So we're addressing this currently through holding some vacant positions in our WIC program in the administrative capacity. But we are also going to be addressing that likely through local budget asks for fiscal year 27 to try and shore up any holes that this obviously causes with the reduction of funding to this amount.
Any additional questions? All right, hearing none, are we ready for the vote? All in favor of approving the grants and contracts consent agenda? None opposed, motion carries. Thank you, Mr. Diamond. Next, we are back with Dr. Ariola, report of the director.
Good afternoon, Chair Franklin, members of the board. You do have the director's report with you. I do want to point out a few things. One, we begun offering flu vaccines at all 3 of our preventive health clinics, and they are available by appointment Monday through Friday at East, Woodbine, and Lentz, and they are recommended for all people ages 6 months and older. On the 4th page, I do want to update you, as you will see also in the update that I sent out about the performance metrics, where we are with the community safety piece. We're making a lot of progress. We expect the mayor is working with us on finalizing details about the task force. And internally, we are making a lot of progress on the logistics. Internal groups met a couple of times now, the larger team, and working on the logistics, and also finalizing contracts with the consultants. So we expect to get this going very, very soon. Opioids, the RFP, I believe it was sent out finally today to downtown. So we are making progress there. It's still going to take a while. The Metro process is lengthy, but we expect the RFP to be out, and we'll begin the process of trying to select vendors that can do some of the work. And Woodbine replacement. I actually was hoping that I would have some much better news for you. We were very optimistic about the site that we've been looking at for these past several weeks. Unfortunately, that fell apart yesterday. We have seen the site, and we like the site, and we considered, because it's a large facility, we considered moving multiple programs and freeing up a couple of buildings. But it turns out that the property is under the real estate investment trust fund, and it's only available for lease, not even lease purchase. So I don't think that we want to lease and then be trying to move again in a few years. So we're working with general services and looking for, we still have one site, and then looking for additional sites. We're also working per the mayor's instructions with general services to put together the what they're calling benefit analysis of the need for the facility. So when I spoke to you last week, I thought I would be presenting to you PowerPoints that we finally crossed the line, but we got another huge setback. But I can tell you that the mayor is very supportive of our effort, and hopefully we find another site very soon. For animal care and control facility, we have finally, I think, the consultant has done the report, right, John? Yeah, we have the report that we think will guide selection of sites and other things. So we expect movement around there. I think, I don't know how much detail I put in the report to you, but we met with the Mayor's Office of Strategic Partnership last week. And it seems like, without throwing out names here, but some Nashvillians have interest in working with the Mayor's Office and us in ensuring that we build an appropriate new MAC facilities in the county. So we think this initial thing is enough to begin a series of events that we think will be very helpful towards a new facility. That's it. That's all right.
Any questions for Dr. Ariola?
Can you give us an update on the change management effort and where we are with that?
I think you will be hearing from the board chair. I think the report will be ready next week, and we plan to share the report broadly with our staff, but I also don't want to get into how the board wants to handle this. So I've linked Anna with Tene, so Ms. Franklin, I'm sorry, so they can work that out. But with us, I expect a report to be ready with recommendations, and the plan for us is to get with our staff, get feedback on those recommendations and additional things that we can do towards becoming a better organization.
What about strategic plan?
Yeah, I put the update there. We are making progress. We have Cabera is over, that's finished the next round of analysis. She will be presenting that to the ELT next week. And then the next plan is to present that to the broader department and get input from them. And there's also a step to get feedback from the Board of Health. But it's the target is to complete that by February, but we think we'll be done before then.
Thank you.
Yeah. I did include some of the updates, but I know we kind of gave it to you at the last minute, but you have to, yes.
Any other questions or comments?
I'm sorry. Dr. Fonda Harris, who has been with us for 35 years, is that correct? 34 years. I believe this is going to be her last board meeting that she's attending.
You stole my
thunder.
thunder.
I'm quiet.
You stole my thunder.
She's my staff, I'm sorry, go ahead. All right. But I do want to recognize what she's done for the department and wish her all the best. So, go ahead.
Well, I'm the next agenda item, so I will continue. I'll take the baton. So thank you, Dr. Ariola. So when I first came to the board, Dr. Harris was the first time I really got a chance to talk to Dr. Harris and start to get to know her. We were at a session downstairs in Centennial. It was the Racial Equity Institute, and we had community groups here. We had individuals from ELT and others in the department where we were able to come together and talk through for 2 days the historical understanding of why we do what we do to address inequities and disparities in public health. And I was struck by Dr. Harris's, how she engaged with grassroots community members, how she held firm to her belief with regards to really walking the talk in terms of not just doing public health to the community, but working with communities in order to hear voices and elevate those. And you have not changed. And like Dr. Ariola said, it is with much appreciation that we say thank you to your service for the department, being here 19 years, and also being with Metro for 34 years. You're one of those quiet leaders. I don't always hear you talking, and when I ask for something, you always fall back. But your strength leads, and your leadership and how you hold community for members of the department really speaks to the work that this department does. So I just want to say thank you for your service to this department, and we wish you the best. If there's anything that the board wants to say, Dr. Ariola, please, because she is your team member, but if you want to add to that.
Right, and we'll have the opportunity before she leaves, but so Dr. Harris, I've known really, I think, most of my time here at the health department, and you alluded to, and I think I've shared that over the years with her. The one thing for me is the maturity. It's staying calm no matter what the situation is, and always working on the side of trying to get things done rather than promoting conflict and the other non-beneficial things. So for several years here, she was the brain and the person behind Safety Net Consortium, along with Bat Perkins. So really, Bat has retired for a while now. So even when I wasn't here, I continue to follow what she does. And again, from the bottom of my heart, very appreciative of what you have done. Thank you for your leadership, steady leadership, and all the best to you.
So two things. One, I often ask for feedback. I've asked several of you all in the room for feedback, and Dr. Harris gives me feedback. So thank you for giving me feedback in a gentle way, but you give me feedback, and I do appreciate that because it's in the spirit of growth. And then lastly, you're retiring, but you don't look like you're retiring. So I'm just going to need your genes or something of that nature. But we wish you the best and look forward to learning what is next and how you will spend retirement. You've got that smile on your face, so yes, but thank you. Okay. For the second part of my report, in the spirit of feedback, Ms. Anna Boone met with several members of the department and the board in July and August, just to help make of everything that's going on with our change management process. And as I understand, the report is ready, or at least almost ready. And so we're in the midst of scheduling. I'm scheduling time with Ms. Boone to meet one-on-one to discuss the findings of the report and how it will be shared with the board. What is the best way, considering? And I also believe it's going to be shared with the department in a format, right? So that's what I'm going to champion and advocate, because we're all in this together, and we want the best for our residents and for the department. So stay tuned. Right now we're literally trying to schedule time, but it's coming. So yes. The third thing, NALBO meeting is in Savannah at the beginning of October. I will bring a report back, hopefully to the October meeting if we have time. If not, it'll be the November one, but I'll try to have it ready for October meeting. Okay. That's all I have. Any questions for me or feedback for me from my colleagues around the table? Okay. All right. Thank you. That takes us to the almost the last agenda item, which is new business. The board requests of the department and the departmental requests of the board. Right right here. So if you would like to take a moment, and if Dr. Areola, is there anything that you would like to highlight?
Yeah, the only of everything else we have provided to you. Two things, number 7 and number 7, 8, and 9. So number 7, I did check with Latissa Hall, and I think very soon the youth advisory board members will be here. It was tough during the summer. Now they did ask me what they will be doing here. So first of all, we're just going to tell them to be here to observe and participate as needed, but we don't want to put any pressure on them. And so Latissa is working with them to clarify those things, but I expect them to be here very soon. Yeah. Is that consistent with that? Okay.
That is correct. We're still trying to define what that will look like, so they won't feel that they're wasting
Their time, yes. Then in terms of talking points to the board members, we're going to share. I was hoping that we'll be sharing some of that around the Woodbine facility because I thought we were pretty close, but we will mark, and we will do that around some of the things that we presented to you, the SGI information today. We're going to be having a budget request based on these things. We also have the similar strategy going on for tuberculosis and trying to get resources for those things. So those budget asks are some of what will be providing talking points for you to help us advocate for things. Now, I should mention, and I don't know how Chair Franklin wants to handle that, Christian is overseeing the funding thing, and we are making a lot of progress, doing some background work. She'll be convening the team in the next few weeks to start talking about the Metropolitan Health Department Foundation and seeking funding sources. We've got a few people that will be members. I know people here wants to be a part of it. So, but we also know that if you have more than one, then Derek will talk about noticing, which is an obstacle. So something that you will need to.
Can we at least get an initial conversation with Ms. Zach?
Yeah,
So,
okay. All right. We'll do. Yeah.
I have a question.
Okay.
Is it possible to get dates or something more specific? It says provide one-page report on each grant annually and provide outcomes, and that's in a couple of places here. But we've been asking about that for 2 years, and I don't think we've ever seen it.
No.
And so
No, actually,
I just would love to hear the plan.
Actually, the grant, you only asked us for that last month.
That's at the end of the, right, that's a new one.
That's a new one. I'm talking about that.
Since you've been here.
Yeah.
Which one?
Since you've been here. Since we've been.
Yeah.
Which one?
All of them.
The grant updates.
Yeah.
No, what number is
It
that?
was explicit last.
No, that was, I just heard about it last month from you guys.
But we have been asking
Okay.
continuously before your tenure.
okay.
So this
We-
is a
Especially
carryover
outcomes,
request.
Okay.
right? Like we set out to do X.
Okay.
We accomplished Y.
Right. So what
Does
we're
that make sense? Or we
yeah.
accomplished X.
Okay. I
Plus
know you
Y.
guys talked about it briefly last time. So probably what we'll do is next meeting, let's try and maybe do one and present the format to you and see if you like that. So,
Wonderful.
Okay.
Yeah, just a comment about that. I think it's probably hard to set one date because terms and contract dates are so different across the board, but just kind of the cadence for knowing that will happen for each one.
I was thinking of just finding a fairly simple one that we can just kind of create a template to see. Some of this, like Dr. McDonough was saying last month, some of these the reports are extensive. But we'll take a stab at it and just, I think I know what you're looking for. We'll take a stab and see if he answers your questions.
Great. And yes, I agree with you that I know that they're not all on the same cadence. So, I would think we would have that, whatever is up, right, hitting that annual marker at the meeting we're coming to. Does that make sense?
Yes.
Okay.
Yes.
Thank you.
Dr. McDonald.
So I'm thinking about, and this is not having to do, I don't know if this is the right time in the agenda, just thinking about how we can help with vaccine messaging. And obviously respiratory season is quickly approaching, and all the things that need to be sorted out with COVID vaccine notwithstanding. if there, I don't know what kind of social media you guys might be planning, but just an encouragement for the board members and others to repost that. And if it's helpful for you all, I'm out of town on Fight Flu Day. I was like, oh man. But yeah, if we can all, it's normalizing vaccination that we need to do. Like, this is just what we do. We get a flu vaccine.
And
like,
piggybacking off that,
Yeah.
we don't have to reinvent the wheel. There are already public health communication
A
messages
lot,
that are
yeah.
values aligned that meet people where they are, right?
Exactly.
Yeah.
And so just if there are ways that we can help you with that, if you want us all to get a flu vaccine at the next board meeting, however we can help you.
We might just take you up on that. So yeah, I think it sounds like a good idea. Just publicly take those things. Yeah,
Take advantage of every opportunity to
really,
normalize this. Yeah.
I don't want to call Matt out now because we'll probably, let's give you an update next week. But there's a lot of efforts going on around what you're saying about. But we will go through you and help us disseminate those information. So, yeah.
But that is officially a board request.
Okay.
So
All right.
we just want to make sure that that's captured. Yes.
Okay, 2 requests. Can we get updates on the WIC situation as well? The WIC grant, WIC situation, like if the WIC clinic needs more funding based on what was shared here. And then the other thing is the community safety initiative. Can we have regular updates from you, maybe Dr. Ann, about what kind of where that is? And
I have the updates in what I sent you.
but I mean, like ongoing.
Yes,
Just-
yeah.
okay.
We plan to give you, I expect a lot of development in the next few weeks, but we'll give you the updates regularly. Yeah.
Community violence updates on a regular basis, and definitely one next month. Well, I know that there's something in the packet, but just ongoing updates for community violence. Okay. If there's nothing else, I will entertain a motion for adjournment of the Board of Health meeting, portion of the meeting. Motion made by Dr. Ziegler, seconded by Dr. McDonald. All in favor? All right, thank you. None opposed. Meeting is adjourned.